I'm going to try to provide you all with an update about anti-amyloid therapy and hopefully be able to answer all your questions. And unfortunately, while I'm kind of going through this, I can't see all of you, so I'm kind of looking at just my own slides. But at the end, I'll be able to answer questions. So here are just some of my disclosures. I have worked with some of the companies that developed these drugs as a consultant, and actually was the site investigator for the clinical trial for aducanumab, which was the first approved medicine in this class. So as an overview, I thought what I would try to talk about is first, kind of just a little bit of background on why we're even trying to target amyloid in the brain. What's sort of the goal of trying to reduce that particular protein in the brain. I'm then going to provide a little bit of data from the phase 3 trials and some of the more recent data that has been associated with these drugs, particularly the two fully FDA-approved drugs, donanemab and lecanemab. And then finally, I'm going to talk a little bit about how we evaluate and manage patients at Penn, and hopefully that can lead into some discussion. All right, so what are the pathologies of Alzheimer's disease? A little Alzheimer's 101. As probably many of you know, we talk about the plaques and tangles of Alzheimer's disease. The plaques are made up of a protein called beta amyloid, whereas the tangles are made up of a protein called tau. And it turns out that they have slightly different distributions within the brain in terms of where they occur. And they do have, as we'll talk about in a few minutes, differences in the timing of when they occur in the brain, with amyloid generally occurring earlier than tangles. And one of the real big advances in Alzheimer's disease research is we can image both of these kinds of proteins that build up in the brain. So we have ways of imaging amyloid plaques with amyloid PET, and ways of imaging the tangles of Alzheimer's disease with tau PET. And again, based on a lot of data that have come from autopsy data, but also from imaging data, there's a lot of evidence that amyloid appears to be an initiating event in the course of Alzheimer's disease, such that, and these are sort of cartoons, but initially individuals will have amyloid in their brain without really significant evidence of tau that we can pick up on tau PET. And then over time, tau tends to accrue in a part of the brain called the medial temporal lobe, which is where the memory circuits of the brain sit, and why memory is often affected early in the course of the disease. And then over time, tau tends to spread to the rest of the brain. Meanwhile, amyloid doesn't tend to go up too much over time once it sort of reaches a plateau. So the basic thinking, though, is amyloid is an early event in the disease course of Alzheimer's disease, whereas tau is a later event, but tau is much more related to the symptoms of the disease. And so where there's tau in the brain, that's where the brain is affected, and whatever functions of that area in the brain are subserved by that particular area, that's the kinds of symptoms that people get. So that's sort of the basic idea of Alzheimer's disease. Where does amyloid come from? Well, it comes from a protein called the amyloid precursor protein, which is a protein that's abundant in the brain. And there are different enzymes that break this protein up. And depending on which enzymes break it up, we either get the A beta that forms the plaques that are bad for Alzheimer's disease, or we might get other sort of fragments of the amyloid precursor protein that are less damaging to the brain. And in fact, there have been a number of drug trials that have tried to target things that influence these enzymes to try to push amyloid towards a kind of less toxic form of it to protect the brain. One of the things that I think makes many of us feel that amyloid is a really important piece to driving Alzheimer's disease is that the genetics of Alzheimer's disease, at least the genetic causes of Alzheimer's, are all associated in some way with amyloid processing. And so for the most part, Alzheimer's disease is what we call sporadic, meaning that there's not a single gene that causes the disease, that it's a mixture of many different genes and environment and other risk factors. But interestingly, in about 2%, whoops, it's moving without me moving it. In about 2% of cases of Alzheimer's disease, it's due to what's called an autosomal dominant mutation in a gene. And this is where if you have that mutation, you're going to get the disease. And if you don't have it, you don't get the disease. And so families that have these mutations, half the offspring of that family member will go on to develop Alzheimer's disease. And the reason I bring this up is because these mutations are all involved in either the amyloid precursor protein itself or on enzymes that are involved in breaking up the amyloid precursor protein. Alternatively, there's very rare mutations of the amyloid precursor protein that are highly protective against getting Alzheimer's disease. And there's some interest in using these mutations for gene therapies in the future. And then finally, the amyloid precursor protein is on chromosome 21. We have 23 chromosomes, and all of us carry 2 of them, but there can be this sort of aberrant sort of genetic signature called trisomy 21, which is associated with Down syndrome. And all of those patients develop Alzheimer's disease, or all those individuals develop Alzheimer's disease at some point in life because they have an extra copy of the amyloid precursor protein. And again, I bring all of this up really because I think sometimes we talk about using anti-amyloid therapy and what the motivation is. Well, the motivation is it seems that the genetics of this condition is really saying that amyloid is an important driver of it. ApoE4, which is something a lot of you have probably heard about, is a risk gene for Alzheimer's. So it's not one of these autosomal dominant forms. And it too has been associated with amyloid as well. So again, amyloid is important. And that has led to probably something you may have heard referenced, which is the amyloid hypothesis, which is that amyloid is the driver of a lot of the downstream negative effects that occur with Alzheimer's disease, and has led to the idea that removing amyloid, preventing amyloid, stopping some of the effects of amyloid is the best or one of the better targets for trying to treat the disease. And there's actually been decades and decades of work trying to come up with drugs that influence amyloid to try to slow down or halt Alzheimer's disease. And probably the approaches that, at least in mouse models and now in humans, have shown the most ability to influence amyloid in the brain are when we give people so-called immunotherapies, which are when we give people antibodies that bind to amyloid in a variety of different forms and cause an immune reaction in which amyloid can be removed from the brain. And there have actually been multiple different immunotherapies that have been tried prior to the approval of lecanemab and donanemab. And one of the things that's really important to point out is that these different immune therapies target amyloid in different forms. And so amyloid starts off as a single molecule, and then it clumps together, and it forms more and more clumps to when it finally forms plaques. And these different drugs have different ability to bind to different sort of levels of that clumping together, which influence their ability to clear amyloid from the brain. And in fact, drugs that, and this is a complicated slide, but basically the message is that the immunotherapies that did not clear amyloid very well or didn't clear it at all, such as a drug called solanezumab, which was in 3 different phase 3 trials, which is the sort of final stage before approval. Drugs that did not clear amyloid well did not have much of a clinical benefit. And really, the drugs that ended up getting having successful trials like donanemab, lecanemab, and aducanumab, all were drugs that for the first time were really effectively removing amyloid from the brain. And part of the reason why I bring this up is some of you may have heard there was an article that came out recently that looked at all of these drugs as a single class and said, well, when you combine them together, these drugs don't work very well. And there was a New York Times article about it and other articles that had come out in the media about how this so-called meta-analysis showed that these drugs don't work. And the reality is that it makes absolutely no sense to combine a bunch of drugs that failed to hit their target of reducing amyloid, as well as failed their trials with drugs that are effective. And so I think that that created a little bit of a media stir, but really is kind of a meaningless result. Okay, so with that background, there are now, as many of you know, 2 approved anti-amyloid immunotherapies, and they both have a strong effect, as I've said, on removing amyloid from the brain. And so what this particular figure shows is that when the line here reflects the degree of amyloid in the brain from start to the end of the trial over 18 months. And if you're on placebo, there's like a kind of slow increase in amyloid over time, but not much. When you're on the drug, though, there's a pretty rapid reduction of amyloid, such that with, for example, donanemab, about 4/5 of individuals by 18 months no longer have a positive amyloid scan. And this is an example of a patient in our center that had a positive amyloid scan to start. And just to give you a little bit of inside baseball, the way you can tell that is that the cortex, the outside of the brain, looks very smooth and dark, which means that the tracer has gotten out to the cortex of the brain, or the gray matter of the brain where amyloid is. And then after treatment, that's gone. And this scan looks no different from a normal adult who didn't have Alzheimer's disease. And so it truly is remarkable what we see, at least biologically, with these drugs with regard to reducing amyloid, which that in and of itself is a major achievement and an important sort of accomplishment in our ability to really influence the pathology of disease. But of course, no one really cares about what their scan looks like if it doesn't affect them in terms of their thinking or the change in disease. And what you see is that these drugs have a modest slowing of the course of disease. This is comparing lecanemab and donanemab with one particular measure that they both used. And basically what we see with these drugs is that there's a slowing of the disease by about 1/4 or 1/3. And I would say that while this image suggests that lecanemab is a little less effective than donanemab, in reality, depending on what measure you look at, they're pretty similar. And so, one way to think about this is that if, in a typical 18 months, you were going to decline a particular amount, you on these drugs would decline as if it had only been a year in slowing down the disease. So a modest effect, but does certainly slow down the course of the disease and pretty convincingly across both of these drugs. Well, I think that's sort of an abstraction. It's a measure, that particular scale we looked at is a measure of cognition and function, or thinking and function. One thing that they did in the lecanemab trial is they also looked at a bunch of measures of quality of life, both for the patient and care partner. And these drugs also seem to slow down the decline in measures of quality of life for both up to close to 50% for a measure of quality of life for the patient, and by study partner in terms of burden, for example, there was a slowing of about a third. And so really potentially impacting the quality of life for both patient and care partner. Another way to think about the benefit of these drugs is to look at how over the 18 months of the trial, they influenced the progression to a later stage of disease. And in both cases, the drugs basically reduced the likelihood that you would go to a later stage, sort of later clinical stage of disease, like from mild cognitive impairment to very mild dementia, by about 30%. I think one of the things to keep in mind, though, is Alzheimer's is such a slow-moving disease that even the placebo arm, only about 30% of people progress to a later stage of disease, compared to on treatment, 20% progress. So that's that 1/3 reduction. But the reason I bring that up is just to say that, Alzheimer's is very slow moving. That in some ways is good. Obviously, that many people over 18 months, even without treatment, don't show a lot of change. But it also makes it really challenging to show a really robust effect in an 18-month study with a drug, because we're dealing with trying to slow down a very slow-moving disease, and that can be a challenge to statistically show an effect of the drug. Who do we treat? Who was studied in these trials in terms of who got the drug and stage of disease? So recently there's been this newer staging for Alzheimer's disease, which are stages 1 through 6, where 1 is people who have preclinical Alzheimer's disease based on evidence of amyloid in their brain, but no symptoms. Stage 2 is a kind of transitional subjective stage where people notice symptoms, but maybe don't have evidence of them on testing. Stage 3 is what we often refer to as mild cognitive impairment, which is when people have changes in their memory and thinking that might affect the efficiency for which they do day-to-day tasks, like balance the checkbook. They just might be a little slower at that, but they're still able to do it on their own. Whereas stage 4 is what we call mild dementia. And dementia really is just a clinical term that means now you need some help for some of those more complicated functions of things like the checkbook or cooking and driving. Stage 5 and 6 are then further stages of dementia where other more basic functions tend to be affected. The bottom line is these drugs really were focused on what we're calling here stage 3 and 4, which is mild cognitive impairment and mild dementia. And it turns out that now, in looking at data from both of these trials, both the lecanemab trial and the donanemab phase 3 study, both of them have shown that when you look at patients with mild cognitive impairment, or when you look at patients who biologically are an earlier stage of disease, even within that narrow window that were treated in these studies, that they seem to do the best, and that you see even more robust slowing of progression of disease, now up to 50 or 60%, for example, of people with mild cognitive impairment in the donanemab study. And this fits with the idea that in general, these drugs are going to be most effective the earlier we treat patients, before there's been a lot of more downstream injury to the brain. And I think it's really encouraging, particularly because there are now trials that hopefully will read out in the next couple of years, where we're treating people before they have any symptoms at all, with the hope that it would really significantly delay the onset of the disease, or maybe even prevent it. Another thing that's come out recently, and these are hard studies to do, but that there have been now what are open label phases of these various drugs, or of lecanemab and donanemab, where people have been kept on the drug. In the case of lecanemab, and as I'll talk about later, donanemab, generally we stop the drug after around 12 to 18 months because of clearance of amyloid, but where people have been followed out over time and compared to matched people who have never been treated with the drugs. You can't really do a placebo arm because that wouldn't be ethical in terms of denying people treatment. But these are sort of historically matched patients that are very well matched to our treated groups. And the take-home point is that at 3 years, and there's now data at 4 years, it seems that the slowing of disease continues to accrue, such that by the end of a year and a half, you've gained 6 months, and by the end of 3 years, now you've gained maybe a year of time. And so it does seem like these drugs have an effect that is longer lived than just the 18 months of the trial. And that's been shown with lecanemab, and importantly been similarly shown with donanemab over 3 years and longer with data, which is important because donanemab is an example where we're actually stopping the drug once clearance has been achieved. And so this effect continues to accrue over time, even though you're not getting the drug in many cases after 12 or 18 months. Of course, these drugs are not without side effects, which the ones that you hear the most about is something called amyloid-related imaging abnormalities, either edema, or E, and or hemorrhage, H. And the reason these are called imaging abnormalities is because the vast majority of patients with these don't have symptoms. And so it's something that has been picked up mostly based on imaging. Edema is fluid or swelling, which can often be quite subtle. So hopefully you can see my cursor, but this little bright area here is a small area of swelling that would be ARIA-E. And this is another patient with ARIA-E in the back part of their brain. And then microhemorrhages show up as these sort of black dots that we see on a sequence on an MRI, a picture that you get with an MRI that's sensitive to iron, which is in blood. These look much bigger than what they actually are in the brain because they kind of expand on the image, which is how we can see them relative to how microscopic they are. But these are the microhemorrhages that we see with ARIA-H. And these are very common with these drugs. So having any ARIA at all with lecanemab in the trial was about 1/5 of patients. And with donanemab, it was actually about 1/3 of patients, although I'll note that there's a newer form of how the dosing occurs with donanemab that brings its number down much closer to what lecanemab is. The important point is that and I would just say, to take a step back, ARIA-E, that swelling, much more so than those little tiny bleeds, are sometimes associated with symptoms, and really more what we worry about clinically in patients. But in those cases with ARIA-E, only about 20%, 25% of them are symptomatic. And so 75% of the time, people will have this on an MRI that we do as surveillance, which we get fairly frequently, but will have no symptoms of them. The other important point is the vast majority of those cases, including the symptomatic cases, reverse or resolve over time. However, this is showing what we call a serious adverse event, or a more significant side effect. About 1% to maybe 1.5% of the time, these symptoms can result in a very serious event, which can include anything from stroke-like symptoms that don't go away and aren't reversible, to seizures, to death. And so I think the way I frame this medicine with patients is that these drugs are generally pretty safe. And even when people have this relatively common side effect, it's almost always either asymptomatic and or reversible. But these drugs have a non-zero chance, about a 1% chance of some sort of very serious adverse event. And that's how people need to think about the risk of the drug and how they balance the risks with the benefits. As some of you know, your apolipoprotein genotype, which is, again, ApoE4 is a risk gene for Alzheimer's disease, that also seems to influence the risk of ARIA in the brain, although it's not clear it completely influences the risk of a serious event, that 1% number. But certainly people who carry 2 copies of this gene are people we worry about the most, who are most likely to have this ARIA side effect. And that's why we get that genotyping in patients ahead of time so that we can best tell people about what their risk is. All right. So a couple other new things now, relatively recently, lecanemab, a subcutaneous sort of auto-injection version of this drug, kind of similar to like giving an insulin injection, has been approved for maintenance therapy after people have completed 18 months of the therapy and have shown good clearance. Subcutaneous lecanemab provides, which is given weekly, provides very equivalent amounts of the drug in the brain to it coming in for monthly infusions, which is how we would give lecanemab after the initial every 2-week infusions that we give the drug. And so that's exciting because that offers the possibility of not needing to come into the infusion suite. And right now the FDA is deciding whether to cover a version of this subcutaneous form of this drug at initiation so that people don't necessarily ever have to come in for infusions and can start the drug at home. How do we give these drugs? I've already alluded to this, and many of you know, donanemab is a monthly drug, whereas lecanemab is every 2 weeks. Both of these drugs, we get MRI scans at a pretty high frequency over the initial period of the drugs, such that we get a baseline MRI in both of them within a year of start to assess for risk. And then monthly, we'll get an MRI for the first 3 months of treatment for both drugs. And then we will also get an MRI at 6 months and 12 months and potentially 18 months. And the reason we get so many MRIs early is if people have ARIA, they tend to get it in the first 3 months of treatment, maybe the first 6 months, but then the risk tends to go down quite substantially, which is why we also caution patients that when you start these drugs, it makes sense to try to not travel too much or be too far away from medical care in the first 3 to 6 months of treatment. Of course, that is not a absolute, depending on what people are planning to do and their own sort of risk assessment. So as I mentioned, these drugs clear amyloid from the brain and they will do so to variable degrees at different time points when we assess them. And in donanemab, I mentioned earlier that we check in a PET scan at around 12 months after treatment, because in the trials, about 2/3 of patients cleared amyloid from the brain at 12 months. And so those are patients we could potentially stop on the drug at that point if they fully cleared. If they've partially cleared, well, then we make decisions about continuing therapy. And so, again, we now get amyloid PET scans at some point to assess whether or not the drug has been biologically efficacious, that it's hitting its target. And so with donanemab, given it tends to clear a little faster than lecanemab, we check at 12 months. and we discontinue if there's full clearance. And then we check again in 18 months. And at that point, we expect about 80% of people to be cleared, and we would discontinue them. If they're not cleared at that point, then we might consider continued treatment. Of course, if we're not seeing any real evidence of clearance, then sometimes we think the drug's not hitting its target and we might discontinue because it's not working effectively. Lecanemab, on the other hand, we check at 18 months. And if there's substantial clearance, there we'll start maintenance therapy where they'll either get the monthly infusions or subcutaneous treatment weekly, if that's what they would prefer, the patient and family. However, if there's not complete treatment, we may continue on with the initial every 2-week dosing. But really, people want to know, how do we know if the drug is working? And the problem is, it's really, really hard in any individual to know if the drug's working. It's easy in a trial because we have a placebo group that's randomized, but any individual is very difficult. And it's made even more difficult because Alzheimer's disease, as many of you know, has a very heterogeneous or differential effect over time in how people develop symptoms. And so I like to put this slide in talks because it shows actually that measure, something called the Clinical Dementia Rating Scale that I showed earlier as the outcome measure for these trials. And each line here represents a different person, and it's over 24 months of a different person with Alzheimer's. And the point is, there's incredible range of people who progress very rapidly, people who don't progress at all, and everything in between over 24 months. And so it's always hard in any individual for me to say, well, you're doing, about 30% better than I would have expected you to do. I will say we're working very hard on the research side to come up with ways to model that and to better predict that. But right now, clinically, really, it's hard to know how well the drug is working clinically in any individual. And at some level, we kind of take as faith what we know from the sort of natural history of the disease. How do we evaluate patients at Penn for these drugs? Well, first we got to clinically determine whether you have mild cognitive impairment or mild dementia. And that's based on our cognitive testing, but also talking to families about what kinds of functions and things the person's able to do. We get an MRI to rule out things that would put you more at risk. So in general, people with Alzheimer's do get microhemorrhages, those little bleeds that we call ARIA-H, even without treatment of these drugs. And it turns out those that have more of them tend to be the people who are most at risk for further ARIA, and therefore we don't allow people to be treated with these drugs with more than 4 microhemorrhages because of safety. We have to confirm that we have the right diagnosis, that Alzheimer's disease is driving symptoms, and generally we do that with amyloid PET now. Sometimes we do that with spinal fluid. Occasionally we get tau PET because that can be really helpful in us determining whether or not symptoms are due to Alzheimer's, because if you have a negative tau PET, it's unlikely that even if you have amyloid, that Alzheimer's is the driver of your symptoms. As I mentioned earlier, we do genotyping, and we also check for basic blood work. Why do some people decide to and not to pursue treatment? And I think whenever we think about these treatments in patients, we have a conversation with both the patients and the family members, going over the risks and benefits and really trying to come up with what's the best decision for any patient and family, keeping in mind that rational people want these drugs, and rational people sometimes feel like they are less interested in pursuing these medicines. And the things that everyone has to weigh are risk and benefit, but we all have different risk-benefit profiles. Some people think that 1% risk is like, well, this is a bad disease, and if I can slow this down and have more months of being able to do things with my family and friends, then 1% sounds like nothing. Other people say 1% risk of even potential death. Well, that sounds very scary to them, and they might not want to choose the medicine. One of the other things that's really important for deciding to pursue treatment is having a care partner, family member, really close friend who is available for infusion visits. Sometimes people can have allergic reactions at infusion visits, and so we need someone there. But we also need someone to kind of monitor and check in on the patient to make sure that they're doing okay, so that if they are having side effects, we can address them appropriately. And a big reason why people choose or not choose to pursue this treatment is how much they view the coming in for infusions and MRI scans as an inconvenience in their life, and how much they, would rather not dedicate the kind of time and effort that's required for these medicines. What happens after we decide? Someone says, yep, I want to go on and take this drug. Well, then we actually, because these are still relatively new drugs, discuss every case at a case conference on a Monday, review all the imaging and history and measures that we have, to make sure that everyone's on the same page, that we think the patient is appropriate for treatment. And then if they're approved, there's a team that works on an insurance determination and scheduling, which is very complicated, obviously, because it's trying to coordinate MRI scans and infusions with a person's personal schedules. We will have an onboarding visit after someone is approved, where we'll get baseline assessments. Usually that's with our nurse practitioner, who's quite excellent. And then we really want to see patients at 6-month follow-up to get testing to make sure that we're not seeing unusual changes in their cognition or thinking. This has required an incredible amount of effort at Penn. So just to give you a little bit of an idea of behind the scenes, there has been need for coordination around infusion medicine, radiology, laboratory medicine, genetics, our neuropsychologists, financial counseling, communication, and obviously the work Allison and others in our social work team play a really big role in helping families think about their decisions in this context, as well as management as we move forward with them. And we had to create a committee actually to work on some of the logistics and coordination of anti-amyloid therapy. So this was a pretty heavy lift, but I think we've got it running well. And so just to give you a few words about our Penn experience, and I'll stop my slides there so I can actually see human beings and feel like I'm a little bit engaged with people. It's nice to see a few smiling faces. The Penn experience so far is we've probably infused around 475 people at this point at last check. That was a few weeks ago, so it may be a bit higher than that. We are finding ARIA rates that are similar, if not slightly higher than in the trials, in terms of the number of them. That's in part because we use a MRI picture that's a little more sensitive than actually what was used in the trials. But in terms of negative outcomes or symptomatic ARIA, that's been much more in keeping with the study. And actually, we've knock on wood not really had one of those very, very serious adverse events, although we have had people with severe ARIA that gets better. A few people have needed even a hospital stay for that. But again, percentage-wise, what we're seeing here at Penn and actually across the country based on data that's emerging is that these medicines are being able to be delivered safely and similar to how what was seen in the trials, which is very comforting because the trials were very prescriptive in terms of how medicines were delivered, and the real world is often much more complicated than in the context of a clinical trial. And so we've been very pleased to see that there has not been across the country much difference from the trials with regard to side effects. So I'm going to stop there and let people answer questions. I went a little over where I wanted to go in terms of time, but hopefully we'll still have enough time to get to a lot of your questions.
We'll see how far we can get. I'm going to there's a lot of similar questions, so I'm going to categorize them. But the first question is, I'm going to butcher this name. The early results for trontinemab seem much more promising than these. What are your thoughts on that, Dave?
Yeah, so trontinemab is really exciting. So for those of you who don't know, this is another antibody that is actually the same antibody as gantenerumab, which failed as a drug in a similar trial to what we saw with lecanemab and donanemab, in part because it didn't clear amyloid as well as the two approved drugs. But what the company has done is used this new approach that's, I think, actually going to revolutionize central nervous system treatment in general, which is to use something called a brain shuttle. And the basic description is that it allows the antibody to get into the brain much, much more easily than what these current drugs do, which you have to give really high doses of the current drugs because the brain doesn't like to allow big molecules in it. There's something called the blood-brain barrier, which protects the brain from these big molecules. And with this shuttle, the antibody gets in much more easily, and it seems to clear amyloid from the brain in a matter of months. So after 3 months in many patients, 3 treatments, and has a much lower rate so far in the trials for the risk of ARIA. And so I think it is an extremely promising drug with regard to its safety more than anything else, as well as maybe its convenience if it can be given over a shorter time frame. But I will say that it's now going into a phase 3 study, and so it still needs to be shown to have the same kind of clinical effects that lecanemab and donanemab have, and also just that the safety profile that we've seen truly is more safe than we have. I think, though, the bottom line is, that yes, these drugs have a modest benefit and they are associated with risk, but there is absolutely no doubt in my mind that even within this class of drugs, that we will have versions that will be even safer in the future and that may actually have also more efficacy. That's just the way drug development tends to work, is you have the sort of first generation of these drugs, and then you build upon that and move towards drugs that might, if just even being safer, that would make a big difference in people's lives and their willingness to take these drugs. So I think we're going to see an evolution there.
Great. Thank you. Okay, two related questions about early onset disease. So one is, do any of these studies include early onset patients, or are there studies specific to folks with early onset disease? That's part one. I'll let you answer that first.
Good, yeah, because I can't hold on my mind
Okay.
more than one part at a time. So the trials weren't specific for early onset disease, but they did allow people, I think, either 55 or 60 was the younger limit of age. So that is getting into the sort of early onset um, presentation of Alzheimer's disease. We have been treating people who have early onset disease, and the appropriate use recommendations, which is sort of an expert panel of how to use these drugs, also recommends or doesn't recommend against using these in younger onset cases, despite not a specific trial for them, because the thinking is the biology is very, very similar. And so, we do treat, there is not a specific trial I know in young onset cases. There are specific trials in those that I mentioned, the autosomal dominant, single gene forms of the disease. There are a number of trials going on. They're very rare, by the way, and people sadly often have symptoms in their 30s or 40s of Alzheimer's disease. But those trials are actually treating people before they have symptoms because they know their genotype with these kinds of drugs. And that will tell us a lot about how these drugs prevent Alzheimer's potentially from occurring.
Great. Actually, related to that, this person is saying that her husband has early onset disease, and our commercial insurance will not approve either the amyloid PET scan, or she suspects these infusion therapies, as they are calling them, investigational. Knowing they're FDA approved and Medicare will cover these therapies, is there anything that can be done to convince commercial insurance that they are not investigational, or are they still considered so?
Yeah, so this has been a real challenge, and I'll get on my soapbox a little bit. Some insurance companies, not all, have taken the fact that when the FDA approved these drugs, they wanted a patient registry to follow outcomes so that they could continue to monitor the safety of these medicines over time. That is still full FDA approval. That's not investigation, but some insurance companies have used that as cover to say, oh, this is still something they're studying as opposed to, a fully approved drug. There are lots of drugs that, by the way, have this kind of registry requirement. We have tried to lobby companies to consider insuring patients. Lecanemab through Eisai does have a program to help with costs for people who have insurance issues. And so some of our young onset cases have gone on to try lecanemab. But that is a challenge, and we will do whatever we can to fight to allow people to get these drugs. Because, in particular, to be honest, we as clinicians feel if anything, most wanting to be aggressive in young onset cases because this is it's a terrible disease at any age, but certainly when a 55-year-old has early onset Alzheimer's disease, we want to give them every opportunity for any of the medications that are available.
There are a lot of questions in the chat of folks asking if you could talk about the differences between drugs like Aricept and Namenda that we've been prescribing for some time versus these anti-amyloid therapies.
Yeah, so the it's a good question, and one I will say neither is a replacement for the other. So we still use those older drugs like Aricept and Namenda in people on these medicines. The difference is that medicines like Aricept, as well as Namenda, essentially treat the symptoms of Alzheimer's disease and kind of make you a little bit better than what you would be if you weren't taking those medicines, but they don't really change the biology of the disease. They don't impact the amyloid or tau in the brain. Whereas these drugs are what we call disease modifying because they change the natural history, the path of the biology over time, with again some data suggesting that that continues to slow the disease down over time. Whereas if you stop Aricept, you basically go to where you would have been if you weren't taking the drug at all at any time point. So it really is a symptom medicine, not a disease treating medicine.
Okay. Are there any studies underway for drugs that target tau directly or reducing tau directly?
Yeah, there are a lot of studies and some really exciting ones to try to target tau because tau, as I mentioned earlier, is more linked to the symptoms of the disease. So once you start developing tau and it spreads, that causes more and more symptoms of Alzheimer's disease. Now, the hope is that if you treat people early enough with an amyloid drug, maybe you could stave off tau from progressing or developing in the first place. That's been a little hard for us to see so far in the clinical trials with things like tau PET for these drugs. But there have been a number of drugs that have targeted and are targeting tau in various phases of development, including antibodies and gene therapies to try to reduce the production of, for example, tau in the brain that have shown some real promise in terms of lowering levels of tau with measures like tau PET. And then coming up soon is something through a nationally funded, is NIH funded consortium. There'll be a trial with a combined amyloid tau drug that's going to target likely cognitively unimpaired people, so people pre-clinical disease, as well as potentially people with mild cognitive impairment as well. But that'll be a clinical trial, not a therapy that we can just give to people. So it'd be a placebo-controlled study. So there almost certainly will be options at Penn for people who are thinking about, or interested in trials for tau targets as well.
A lot of thanks to you, Dave, in the chat. What are your recommendations for staying up to date, not only on anti-amyloid drugs, but also on other areas of emerging practice related to Alzheimer's disease and MCI?
Yeah, so I mean, I think there are a number of resources. I think probably the best resources include, one, the Penn Memory Center website and our communications. We try to keep fairly updated on new things that have occurred in the field. I also think the NIH website on Alzheimer's has actually a lot of really good information about recent advances in the field if you're interested in the science of the field. And the Alzheimer's Association is another really important resource. The other thing I would say, and hopefully if for any of you who are my patients or families, is ask your clinicians at Penn. We're really happy and actually often excited to talk about the advancements in the field because we're kind of right on the front lines of it, and we're always I'm always at least encouraging people to, if they see something in the news, to feel more than free to let me know and ask my opinion about that. Sometimes I haven't heard of it myself, and sometimes it's interesting. Sometimes it's a little off the trail, but I think communicating with us as much as possible is also helpful as well.
Okay, granted, I do not know what this means. So maybe you might need to. Have you ever seen SIADH as an early manifestation of Alzheimer's disease? Could it be analogous to the abnormal gustatory sensations that have been described?
Yeah, no, I haven't. So this is uh, basically a hormonal change that sometimes occurs with brain injury that can cause people to retain fluid based on the oversecretion of a hormone called ADH. I have not seen any connection with that and Alzheimer's disease at this point.
Okay, great. I think we have time for two more quick questions. This person says, because of evidence of previous brain bleeds and genetic factors, a friend has been denied Leqembi. Is it worthwhile to pursue the other drug?
So donanemab and Leqembi, or I can never pronounce. By the way, I use these terms because I can pronounce Leqembi, but I can't really pronounce Kisunla well. But they both have the same risks associated with them. So if you don't qualify for one, generally you wouldn't qualify for another. So unfortunately, that is a big gap in our treatment right now, as there are some people who are just not safe to take these drugs. There is the hope, and there are certainly trials of other mechanisms that may have reduced risk. It could be that trontinemab, if it truly does reduce risk, could be an option at some point in the future. But right now, that is a limitation, and it's our sort of balance of risk and benefit at this point.
All right, and we'll make this our final question for today because a few folks have asked, have any of our research trials or research trials impacting Alzheimer's disease in general been impacted by recent funding cuts, federal funding cuts to research? And if so, beyond writing our local elected officials, is there anything more we can do?
Yeah, so it's a great and important question. So, we have had trials and studies that have been affected by some of the changes in the funding environment. We had a trial that at one point was withdrawn, which was a big multi-site study that was looking at basically ethno-racial effects on vascular cognitive impairment, which is one of the most important things to study in the context of Alzheimer's disease and on its own, and had to stop the study, and then restart the study because eventually, after reviewing it, the government decided to refund it. There's been really a kind of slowness to how money has come out, and also more challenges in what the funding line is for our field. And so I think it's really important to be very vocal advocates, because the reality is that was an influx of money from NIH into Alzheimer's disease over the last 7 or 8 years that has just had a tremendous impact on the speed by which we're learning things. It is true that in science, the more resources you put at a question, the better we get at finding answers. And I think a lot of those resources have led to these drugs being approved, have led to actually the fact that we have a blood test for Alzheimer's disease, many different blood tests, as well as potential other measures that are coming out for other things that affect the brain in addition to Alzheimer's. And so what we don't need now is to slow that momentum. And so the more we can push and advocate for maintaining, the funding within the field, the better chance that we'll be able to leverage everything that we've done to kind of get to where we are at this point and not, have to start over and be less efficient in what we're doing.